Hello, everyone. Welcome back. We will get started in just a moment. As you return, you can turn your videos on if you'd like. Hope you all had a great lunch. All right, I see people rejoining. Lovely to see everyone. All right, let's get started. So this session is a favorite of many attendees. We get to hear reflections from successful AD programs, and we'll hear from those folks in just a moment, but we also want to hear from all of you. So we are going to start off with a chat box question. So if you don't mind heading over to your chat, share what you're proud of. So maybe it's a work anniversary, or you want to give a shout out to a teammate, or you want to share how you overcame a challenging situation. Whatever you'd like to share about what you're proud of from this past year, please write it in the chat box so we can celebrate all together. I'll give you a moment to think about that and what you want to shout out. Lisa starts us off with 2 years in AD with Baylor College of Medicine. Congratulations, Lisa. 1 year work anniversary, 1 year in AD, a new asthma module. Elizabeth, I know you've been working hard on that. Helping a new outreach team accomplish HIV testing linkage at Phoenix Pride. Onboarding 2 new team members. Yay, capacity building. Starting my new career in AD this April. Welcome. The resilience and adaptability of the BC PAD team, coordinating HIV PrEP educational campaign with Maytech. Ooh, cool, Corinne. Glad to hear that. Julia says our team has done some fun things to help build our relationships. Fun night out, the recipe book, celebrating 25 years of RX files with a nice reception, and so much more. Oh, that sounds lovely. May 2023 will be 20 years at the VA. Year 7 with my program. Congratulations, Kimberly, that's amazing. I'll read a few more here. Going from not even knowing what AD was to going above the goals for the program. Yay, Carrie. Celebrating 6 years of AD in Iowa this week. Lexi and Darla, congratulations on the anniversary, and to the rest of your team. Residency program detailing with programs across the state. AD team of phone. Carrie, my freaking phenomenal team at NaRCAD. This is from Bevan, Anna, Anshul, Jerry, Mike, and our fantastic extended facilitation team. Perseverance across the team, constantly shifting and flexing and make it seem so easy. That's from Gwendolyn. She loves her team. I'm seeing some things from upskilling from CEP. Jason saying he has personally been affected by suicide. Making the art of medicine for suicide prevention was personally satisfying and even therapeutic. I overcame my own fears about suicide through the production of this film and the friendship that was created between myself and the main character, Jeff Gold. Jason, that's so nice to hear. And we will all take a look at that video that was shared earlier today. A few more, proud of my team and their commitment to ending the HIV epidemic, all the great professionals I've met, and being made more aware of our other public health issues and how they affect our more focused work. Receiving permission to start a mental health detailing campaign. This was my first one. Luckily, I have Jess to work with, and that's in New Hampshire. Shout out to CEP detailing team for helping develop our heart failure tool and upskilling. Vishal saying he loves NaRCAD. Hugs from Elizabeth over to Jason, and Bevan is saying she loves Vishal too. So thank you all so much. And I'll read this last one from Michelle. Gwen, you are the heart of our AD team. Grateful for you. And Melissa says she's really proud of all the VA presenters today. So thank you all. It's so nice to do that. And Deb says being part of a global AD community of practice. And Deborah is joining us from Australia. So thank you, Deborah. All right.
All the warm and fuzzies, which, you know, we like to have that. That's part of our brand. It's become part of our brand. We like the data. We like the virtual hand holding. So without further ado, we'd like to cheer on some of these newer programs who have really taken strides to show where they've been, and also some of them have been doing work for a bit longer. Anna, I will have you steal the mic and introduce our first yearbook presenter.
Yes, our first presenter is joining us from Utah. I'm excited to be able to introduce Connie Kitchens, the Public Health Policy Manager at the Division of Professional Licensing for the state of Utah. She has many years of experience in public health, with much of it being tied to substance abuse prevention. Connie has been the leader for many grants and programs throughout her career. With pleasure, I'd like to welcome Connie to discuss her team's opioid prescribing work. Connie, welcome.
Thank you so much. And I've just been involved with this program for a year. So I'm new to AD, but have done a lot of education. So I have no disclosures to tell, so we can move on to the next slide.
All right, so we have a poll here. For those of you who don't know what the PDMP is, it's the Prescription Database Monitoring Program. And or management program. For those of you who work in opioids, what does your state call your PDMP? All right, WI PDMP. Some folks have states that just call it the PMP. Casper, I believe that is Kentucky. Or maybe it's not, just the PDMP. Okay, so we have some sort of, standard names here. Some folks have something a little more fun and fancy. All right, Christy, I got that right. Yay. If anybody has anything unique, please pop that into the chat box and we will move on over to the next slide. We are seeing Florida eForce. Ooh. And we also have the NMS maps from Michigan. All good stuff. Back to you, Connie.
Thanks. So when I got hired, I have highlighted here, I was assigned to be over the controlled substance database team and also academic detailing. And I kept hearing controlled substance database, but then I would be in meetings and hear PDMP and I'm like, I'm so confused. So Utah's controlled substance database is Utah's PDMP. So we interchange our names. And as we could see, yes, Casper is good collaborators with us. So happy to see them on board, and as well as many other states. As you can see, our division is quite unique in the many different things that we do. And for those of you that aren't familiar with PDMPs, they are housed in a variety of locations at states in many, many different places. And all 50 states now have PDMPs. The last one just barely came on board recently. So as I mentioned, I got hired to oversee the AD. I had 2 academic detailers, which both left for other ventures this summer, and otherwise they would have been doing this presentation because they did a lot of the work on that I'm going to be sharing. So next slide. So for those of you that maybe aren't as familiar with what a PDMP is, I just want to tell you a couple of things to keep you engaged in understanding where we're heading down this road. So originally PDMPs were really set up to established as enforcement and regulatory tools. And all states that set them up usually set them up for that reason, and also for enforcing drug laws and overseeing prescribing and dispensing of these drugs by healthcare professionals. But this role continues, but PDMPs have really shifted to enhance patient care, which is where the academic detailing comes in, and also assist in drug abuse prevention, treatment, and strategies. So the overriding goal is really to uphold the state laws, ensuring access to appropriate pharmaceutical care by citizens, and state laws deterring diversion. So all state laws are a little bit different. Next slide. In Utah, our state law, next slide, please. Maybe I didn't say that loud enough. Is it stuck? Oh, there we go. In Utah, no worries. We had the Controlled Substance Database Act that already was in existence, but in 2018, the law changed. And not to go into detail about the law, but to tell you what the law changed in 2018 was that all prescribers, the first time they're prescribing a Schedule 2 or 3 opioid, are required to check the controlled substance database, or if they're repeatedly prescribing. So if there's a chronic condition for a Schedule 2 or 3 opioid, they are to periodically check the controlled substance database. Now, the law didn't define what periodic was. And when we talk to people, we say, well, 90 days would be a good time at least to check as a minimum, because that's when passwords get reset within the state. And so, which causes a lot of frustration and angst amongst people. So in Utah, that is what the law is, and that is where our academic detailing really got born out of this law, and money getting set aside for academic detailers to now go and educate prescribers on using the controlled substance database, as well as making sure they understood or had available to them the CDC guidelines, which we know just changed, and Utah had then also kind of ramped up their own version of those guidelines that we put out and shared. Okay, next slide. So who is compliant with our checking our controlled substance database? As you can see on here, our APRNs and our physician assistants tend to be the most compliant in checking the controlled substance database. Also, you can see this is only over a 2-year period that I'm showing you. So these are, 6-month periods, so 4 6-month periods. It was interesting, we had to leave optometrists off of this chart because they were so compliant. They were at 100%, and it would throw or skew our chart off so much that you couldn't actually even see all the other numbers very well. So we are trying to improve this. As you can see, clear on the right side is the state average. And interesting how the data gets checked. It's for all controlled substances if they're checking it, but the law is only that they check it for opioids. So there's a little bit of disconnect. Some of you might think of this in your own training. Doctors are it's being looked at if they're checking for all controlled substances, but the law is only for opioids right now. Okay, next slide. Just to give you a little bit of history of where we're at on that is, so in 1995, Utah was one of the first controlled substance database or PDMPs that originated, and we were kind of on the forefront, and then we kind of got in a little bit of a, jumble, I guess I'd say, and now we're trying to catch up with some people. But in 95, everything was done faxing and paper, nothing was electronic. Then in 2007, we went electronic, and you can see as we were able to start tracking how our usage has continued to increase. And down along the bottom are just some of the highlights of things that have happened in our history of the database that have increased usage. And we hope coming year to really see that even improve more, as we are a little bit behind on our integrations, which I'll talk about later. Okay, next slide. So let's talk about how academic detailing ties to this and how we use it. Okay, next slide. So as you all know, academic detailing, as many of your experts, I've been so impressed being with you guys, and I've got so much to learn in educating in a different method than as a college professor. But so our academic detailers, there were 2 ways that they would reach out to providers, and these are the 2 ways. So our database team would run a monthly report, and they would look for providers who were prescribing opioids, so the Schedule 2 or 3 opioids, but not searching the database. So that's one way we would reach out to providers. And then we would reach out to them and say, hey, we get to invite them. The other piece I didn't mention, there's no teeth in this. There's no penalties for the providers not sticking with this. And I think other states have some of the same frustration, right? Because the legislature doesn't want to make it, a penalty. They say it's the law, but then there's no way for us to say, well, you have to do this. So I've recently talked to a legislator and said, I think we need to think about making some changes if you really want to see some of this change. So our academic detailer would reach out to providers and say, we notice that you're using the database, or you're not using the database, but you're prescribing opioids. We would like to come and talk to you about how to use the database and teach you about it. So that was one way. We had another another academic detailer that would strictly reach out to providers if they had a patient that died with a controlled substance in their system. So the Office of the Medical Examiner then gives us that report of who that patient is, and we send a letter out to the provider with that report, inviting them for academic detailing. And interesting, some of the little cues that happen that make a difference is just like 2 months ago, we changed from that letter going out from a person with a person's email to our email address says CSD patient notification. So the provider sees that there's something more than just a Connie Kitchens or a Marie Francos or someone that's, and we've noticed we're getting more response or more action from that, you know, because we know everyone's inundated. Okay, next slide. So as part of this whole thing, I say, because I wasn't here, did a survey back in 2018 to 2021. And again, thinking about this started pre-COVID and then it finished up during COVID to ask providers if they would take pre-test, pre-survey questions before they had the academic detailing, and then post-survey questions 6 months later. And what was interesting, the people that, the team that implemented the survey, we did not match providers. When I redo this in the future, we want to match providers so we can actually see a difference between them. But you can see we invited 133 prescribers to participate in the pre-survey, 80 completed it, and the post-survey, 51 completed it. And it was just 14 structured questions, which I'll show like 3 or 4 of those are highlighting here. Okay, next slide. Just to give you an idea of who filled out the survey, and pre and post was pretty much identical for the medical specialty or prac care that they were in. So we just did the one slide. So you can see we got a good smattering of all kinds of medical providers that actually took the survey. Next slide. So our pre-survey and post-survey again had about the same amount of males and females. Had one of our questions was, had they had a controlled substance license for more than 15 years? And you can see that went up a little bit in the post survey. And I'll show you the overall takeaway is our survey results did show an improvement in provider use of the CSD after academic detailing. So interestingly enough, this was self-reported. In a few slides, I'm going to show you a way that we actually checked it to see if that stayed as reported. But again, we couldn't match those up because we didn't know who were answering these questions, but we knew who was invited to take the survey, so we could look at those specifically. Okay, next slide. So here's one of the questions. How often do they check the controlled substance database prior to prescribing or considering prescribing a first-time controlled substance? And you can see it's a bit small, but we ask for acute pain and chronic pain. And as you can see in the acute, the pre-survey, so on the left column, very far left, was 16%, and then post-survey it went up to 25%. So we did have an increase. And then also for chronic pain, it went from 28% to 40%. So definitely the providers told us coming in and teaching them how to use the controlled substance database made a difference in them actually using it and checking. And then look at the difference clear on the right about never. So you can see it went from about 21% of never checking the database to only 4%. Okay, next slide. So our next question was, how often does your authorized proxy or delegate check the controlled substance database before considering prescribing? So in Utah, it used to be the law that you could only have 3 proxies under you. It changed a few years ago to have multiple proxies. You can have unlimited proxies. And there's some pros and cons to that. And we've been working on some systems to make that more efficient. And it takes a lot of our team's time to actually do the paperwork for the proxies. But from here, you can see the responses went up quite a bit regarding the proxy checking the CSD. It went in acute care on the left, it went from 21% to 29%. And for chronic care, it went from 26% to 39%. So again, we find sometimes proxies weren't checking because they didn't know, they hadn't gotten certified. They have to like get a background check from us and they have to get certified. So sometimes they just didn't know the steps and the providers didn't know the steps. So that actually helped us with the proxy checking. We were thrilled to see that go up. Okay, next slide. So then what are some of the barriers? You can see time on the left is a big barrier, and it actually went up in the post survey. That time is more of a barrier for using the controlled substance database. But some of the improvements we did see after academic detailing was that now they had said they hadn't had enough proxy delegates, so that changed. They didn't know how to apply for a proxy delegate. They had trouble logging in. They didn't know how to use the CSD. And then you can see far on the right, there are no barriers in the post survey went up. And then we allowed for a big variety of written explanations, but due to time, I'm not going to go through all of those. It was a wide variety, and if anyone's interested, I'm more than happy to share those with you. So the interesting piece then, what we did after that was 6 months after the AD had happened, our academic detailer gave a form to our controlled substance database and said, will you look up this prescriber and see if their behavior changed? And here's where we just have barely put this information together. And as we started looking at it, my informaticist and I decided, let's look at pre-COVID and during COVID, because it all kind of meshed together, and we felt like there might be some differences and some changes to look at. Again, this is not tied to the pre and post survey data because we couldn't directly tie it. We decided to only look at 8-month periods because that's what we could match for pre-COVID and then during COVID. And here's some of the interesting things you might be able to see on here. In pre-COVID, the in-person change group trend is lower than in the phone or virtual. So these were the changes, these were the percent changes in that middle column that the providers had, their actual behavior. So we didn't talk to the providers, we just looked at the controlled substance database. And so this is where some of this is interesting. If you look pre-COVID and during COVID, the behavior didn't really change when they did over phone and virtual calls, which was a little bit different when I talked to the NaRCAD team before we broke it up into pre-COVID and post-COVID. We originally saw, but as you could see, once COVID hit, it had to go all virtual. And we say virtual, probably the majority of them were over the phone, but there definitely were some virtuals. And then look at the difference between the declined AD but stated behavior change pre-COVID and then during COVID. So it over doubled. And our team kind of talked about what some of the possibilities could that be. Is this group more motivated? Is this a group that avoids training? So they were like, we're just going to do it on our own. So, you know, and then another interesting thing, why it went up maybe so much during COVID, did these practitioners have more time on their hands? So when we reached out to them and they're like, no, I'll take care of it, I'll do it. And 29% of them did. Is it because they had more availability to figure it out because they had that kind of lull in patient care as everyone was trying to figure out what to do? These are just kind of our hypothesis, nothing solid yet. So, okay, next slide. So I just wanted to highlight a couple of other interesting things, and next slide, that we have done with our controlled substance database to try and help practitioners in their care. So we've always had external records, except the medical cannabis is new, but it was all a jumble of how they would see it. Now on the first day, some of you guys saw CoImagine present on what they did with dentists. And again, I wasn't here, so I didn't work with them, but we do work with CoImagine also. And this actually just came down 2 months ago, that we put icons on our patient dashboard so a provider can look quickly and understand and see what's out there. So let me just explain what the icons are. Court records are if there's a conviction related to a controlled substance, a DUI or an illegal possession. The little hospital is if there is a hospital overdose, so no death. The medical examiner is if there is a death with a controlled substance in their system. And then the medical cannabis, we just put that is if they have been given a medical cannabis card. It does not tell them any of the details of that yet. That's something in the future we're working on. Next slide. So this dashboard metrics that you saw the other day looked a little bit different because we've changed it greatly in the last few weeks. You can see those patient warnings now on the left that we mentioned. Those only fire if they are active on that patient. So if this patient didn't have any patient warnings, there would be nothing showing. And again, a provider can look at it quickly and see before they had to go in the area below and just kind of mull through all of that text down there. We also added all these question marks. So a lot of times we get questions like, how do you guys calculate MME? Explain it. So if we were to click on the MME, we put how we calculated it. We also put the link to the CDC app that they can download that helps you calculate it. So again, just trying to provide as much information to help providers in their patient care move along the way. And then those 4 metrics circled up at the top, the first one that says NA is the MMEs. We won't even talk about that with the new changes. And then the next one is how many prescribers that patient has been to in the last 6 months, how many pharmacies that patient's been to in the last 6 months, and then is there an active benzo opioid combination? Many states are focusing on this. Interestingly enough, 2 years ago, we had a law put into place that said a provider should reach out to another provider if they're going to provide an opioid and they see they have a benzo. I had a provider reach out to me recently, and she said, in 2 years, I'm the only one that has reached out to another provider. No one has reached out to me. And this is the first patient I had died was because of one of these combinations. So again, trying to just get information out there to the providers. Okay, next slide. So the interesting thing is, as many of you like Kentucky is very well integrated in EHR systems. We're kind of a baby in this, but we're coming along, hopefully quickly. When for providers, it makes the system so much quicker. Now, they don't have all access to all those external records we talked about. They only have those 4 metrics I just mentioned when they connect, at least in Utah. Those are the only required 4 metrics they have to have. But it takes away the need for a proxy. They just can look quickly. And then if we are trying to add on to an EHR integration, just a flag to show there are some other metrics you might want to go in and check the controlled substance database. Okay, next slide. One of our vendors that went from not being integrated to integrated showed that how much it helped their workflow from 4 clicks to 2 clicks, from 3 screens to 1 screen. They went down to being able to look at this information in 1 minute versus 4 to 5 minutes. And those of you that are in patient care know that makes a huge difference. Okay, next slide. So where does this leave us? We actually have some of our next steps were when my 2 academic detailers left, I'm like, we're going to stop and we're going to evaluate this. So we hired a public health consultant. We found our academic detailers aren't getting in the door very much. They're getting 4 to 5 appointments a week. And when they're working full time, that's not a lot of bang for the buck. So we're trying to figure out, the next one says make some tweaks to the laws and rules. We told the legislature when this report's done from the public health consultant, we're going to sit down with the legislator and say, here, we need to think about how this is being run so we can get into more providers. We're also having our whole controlled substance database analyzed by a consultant. We are including a stimulant focus this coming year with our SOR grant, a CDC grant that we got through the state. And then we want to rework our pre and post tests so that we can have matching and maybe learn from some of you guys some of the questions. Maybe we want to add some additional questions. And that's it. The next slide is just my contact information.
Excellent. Thank you, Connie. And I know we do have questions coming. And for those of you who are just absorbing all this great info and thinking about a question, take a few moments and pop them in the chat. Connie, I have a question I'm going to greedily front load while folks go ahead and pop theirs in the chat. So I know you said that you have a consultant, and I'm sorry if I missed this. Did you have folks do side-by-side sort of use or real-time screen use of the dashboard, like any folks to be guinea pigs, while any potential consultants were able to review whether or not the dashboard was easily intuitive or able to be used the way it was designed?
Yeah, the piece I left out on that is before I came on board, there was some professors at the University of Utah that actually interviewed 30 providers, and they came up with these 34 recommendations. So a lot of those recommendations we're putting in practice are from those actual providers survey, which of course the researchers are thrilled that we're using their data, because I had to dig to even find that when I came on board. And then I was like, this is a gold mine. All the work's been done. We just have to, do it now. And so, yeah.
Yep, go in for that digging, trying to find out what's already there versus trying to construct it yourself. All wonderful ways to go. I have a question here from Nicole Seymour. Hey, Nicole, curious what groups consider as targets for number of visits per week or per month for each detailer, assuming that they're full-time?
Yeah, well, that would be a good question for the whole group. That's what I don't know. I mean, a 40-hour week employee seeing 4 or 5 people at 15-minute visits doesn't, you know, when you do cost benefit analysis, it doesn't like come out very good in a picture.
Right, right.
So
Well, I'll throw it to the group to sound off in the chat box as we go for folks who are doing opioid related work, especially with key messaging around checking the PDMP. You know, what are your targets? And again, if you're not, you know, if you have folks on your team who are not full-time detailers, that's fine. Just let us know kind of what some targets are there. That would be super helpful. Mike, I know you have a question. Let's unmute you and to ask for Connie's insights.
Yeah, I was really curious, Connie, about that. You know, this point we were talking about, you know, when you think about how to integrate sort of your program and be successful, you know, you mentioned the challenges with full-time, and we actually got into in some of the earlier sessions on previous days, the question of, especially sometimes with, you know, embedded detailers having the detailing be sort of part of their role and having them flex from others. And so I'd be interested in your reflections on the sort of part-time versus full-time, because especially in the current practice environment, you know, I think unless your structure is very favorable for it, full-time is pretty challenging because there's some times of day that are sort of, you know, AD availability deserts. You know, it's going to be very hard to fill those hours with visits. And so having that flexibility can make a difference. I'm curious in what ways your program's exploring that to move towards sustainability.
yeah, well, interesting. The gentleman from Chicago that was in my breakout group, I can't remember how to say his name. I had a lot of questions for him yesterday, asking him about how they went about it with the embedded program, and also some of the other programs that just hire pharmacists to do the academic detailing. So definitely that's on our radar. I don't know, our consultant, I know she's saying we need to use pharmacists or nurse or, you know, MDs, and we know there's much higher cost with that. But so, yeah, I'm definitely looking towards, I thought yesterday, I was like, I'm going to need a consulting call with NaRCAD to kind of help me work through some of this.
I'm going to guess that was an extended team member of ours as well, Shirag Rator. And Shirag, if you are in the audience and you want to add anything about that to the chat, feel free, but no pressure. We have time for one more question, if there are any. It seems like this was a really rich conversation that brought up some questions, but also some, how could I do this? Setting the bar high for that. And then also, I don't know that we've often heard here at NaRCAD about folks who are sort of on the ground working on the PDMP. And so that's a really neat and refreshing perspective. Maybe we can start, you know, learning from you in further follow-up calls how to make those kinds of connections for other states to kind of find ways to connect with the sort of creators and behind the scenes folks at the PDMP.
And I'll add to that, I reached out to, we have a PDMP TTAC, it's a technical assistance that's funded through the feds. And I told them, you guys have no information on academic detailing tied to the PDMP. And they are taking that challenge on. So I need to hook them up with you guys because they're going to want to do a webinar and some things and provide a resource on their page for all, because many of the states are doing some kind of training around their PDMPs. But like those of us that are new and trying to change, where do we get that information and learn from the others? And I've been doing a ton of digging to try and make that happen for me.
Well, thank you. And I think, you know, just the words like technical assistance in your search bar for PDMP is the way that folks on this call who are working in this topic can hopefully dig up some dirt. So thank you, Connie. We appreciate you. Any other questions for Connie, please feel free to drop them in the chat box and we'll triage them over to her. Many thanks, Connie.
Thank you.
All right, Anna, next up.
Yes, and thank you, Connie. I also had the opportunity to interview one of Connie's colleagues, Parveen Ghani, who was able to start pulling together a lot of this data for Utah's AD project through her detailing work. So you can check out her blog online. But let's hop back on the NaRCAD bus and head up to Canada. It is my honor to introduce Trish Ron, the Clinical Service Director and an Academic Detailer for Centre for Effective Practice in Ontario, Canada. Trish has been with CEP since 2015. She has extensive experience in hospital pharmacy, continuing education for health professionals, critical appraisal of health literature, medical writing, and patient health coaching programs. Without further ado, I'd like to turn it over to Trish to talk about CEP's newest Falls campaign. Welcome, Trish.
Thank you, Anna, and thanks to NaRCAD for the opportunity to present here today. Before we begin, I just want to say we're coming to you from Toronto, Ontario, Canada, which is also the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and it's now home to many diverse First Nations, Inuit, and Métis peoples. And when I use the phrase CEP, that's going to be referring to the Centre for Effective Practice. Next slide, please. Okay, so I'm an employee of the Centre for Effective Practice, as well as a part-time hospital pharmacist at Mount Sinai, and I have no relevant financial or non-financial relationships to disclose. So I wanted to start off by telling you a bit about our service and how we came to the Falls topic, as well as our topic developments and any learnings that we had from this particular topic. The reason that we chose Falls was because we noticed a big practice gap going on in our area. It's one of the leading causes of injury-related morbidity and mortality among seniors in the community, and yet only about 10% of them are actually speaking with the physicians about falls. So we noticed a big opportunity to help community physicians to screen for people who are at risk of falls and help intervene before they end up in the emergency room. So I'll share a little bit about our efforts and have some questions at the end. Next slide, please. So a little bit about our service. We're located in Toronto, Ontario, Canada. We have 6 core detailers and a variable number, currently around 10, of detailers that are connected to a family health team. That is a multidisciplinary team involving physicians, nurses, pharmacists, and other healthcare providers. All of our detailers are pharmacists. And we've been having our service going on in fits and starts ever since 2008. We began doing a diabetes topic, and we came back again in 2015 to help with issues in long-term care with seniors and antipsychotics. And then again in 2018, we came back to help with the opioid crisis. Our funding is through the Ontario Ministry of Health. And we currently have 4 topics and 5 past topics. Each of our topics is accredited by our Ontario College of Family Physicians for what's called a main pro credit, and they have to collect a certain number each year. So our visits count towards that. And we've also recently been granted the authority to visit nurse practitioners as well. So primary care nurse practitioners who prescribe. So those visits also count to their education plans as well. So next slide, please. I think we're going to turn it over to Bevan for a quick poll.
Yes. All right. So thinking about falls, use a short phrase to answer the following question. What's something that happens to a patient or their family when they have a fall? And this could be from your own experiences. What's something that happens to a patient or their family when that patient has a fall? Yes, they get hurt. We want to avoid that. A life interruption, that's a great phrase. PTSD, yes, post-traumatic stress. Loss of independence, absolutely. We've got that one twice, so that's a big one on people's minds. Fear, yes, that kind of being in the back of one's head. I fell, what if I fall again? I see something from Jas at CDC in the chat box. Hip fracture, TBI, traumatic brain injury, nursing home placement, death. Yes, that's the biggest one. Panic. They downplay it. Oh, it's not a big deal. Hip fractures, again, lost independence. So there's a lot of things that happen that really seem to take down that quality of life for older patients, and then of course their families who care for them. And I'm going to wrap up with anxiety, disorientation, and shame. a lot of challenges here. All right, back to you, Trish. Do those seem spot on?
Those are spot on. Thanks, Bevan. And I noticed a few themes happening there. One is the loss of independence, the fear and the trauma that come associated with a fall, the physical injuries and risk of death, as well as the kind of the shame and stigma that goes along with this, where, you know, the thought of losing your independence, you're afraid that if you tell your doctor that they're going to ship you off to a nursing home, you don't want to bring it up. You think it was probably just a one-off and you'll be more careful next time. And that was a lot of what we were hearing in terms of the barriers for patients speaking to physicians, as well as physicians not wanting to bring it up. And so what we found was that these themes were really well illustrated by a couple of stories that I wanted to share from physicians that we actually spoke with. As we're seeing with the poll, many of us have been touched by falls. And one of the first things we'd often do in our visits is speak with a clinician to say, hey, what are your recent experiences? And many, many times we'd find that they had had a very vivid personal or professional experience with falls that they wanted to share that really colored strongly their desire to have a visit and their approach towards patients. So these are just a couple of the stories that illustrate how differently things can go depending on the systems that you have in place. And I just want to say the names, the stories are real, but the names and some of the detailers, some of the details we've changed to protect the patient identities. Obviously the photos are not the real photos either. So the first one is Robert. He's 82, he lost his wife a few years ago. He doesn't have any children or friends really living nearby, not much of a social support system. He didn't show up for a doctor's appointment one day, and this is a family physician who's very involved with their patients. This physician came around to Robert's house to check on him and actually looked in the window of his bungalow, found he'd fallen on the floor of his bathroom. They had to break in and get him. He'd been on the bathroom floor for 2 days. He had broken his hip. He was unable to get up, unable to call for help. And there was no phone or lifeline, so no one could hear him. He survived by drinking water from the toilet bowl, but by the time they found him, he was very weak with hunger and fear, and you can only imagine what was going through his mind during that experience. As a contrast, Marion, who's 78, had a system with her neighbor Sue, who lived across the street from her. She would raise her blinds every morning if she was okay. If the blinds did not go up, then Sue was supposed to knock on Marion's door, and if Marion didn't answer, Sue was supposed to use a key that Marion had hidden under the mat to let herself in to check on Marion. And one day the system worked. Marion's blinds did not go up, and Sue knocked on the door and Marion didn't answer. So Sue used the key, she let herself in, and she found Marion on the floor outside her bedroom where she had fallen the night before. So she had been there for a few hours, she was shaken, but her system had worked. And so she was able to get help sooner. And she actually, from that experience, decided to carry her cell phone in a fanny pack. So that no matter where she was in the house, she would be able to call for help. So these stories just illustrate the severity of what can happen to you if you don't have someone to check on you, and how having one simple intervention, such as asking a friend or a family member or a neighbor to check in on you every day, can make a really big difference in what happens to you if you do fall. So we focused on identifying simple yet practical interventions like this one for our sessions. A little bit around our tool development, just to share how we have our tool development process. We do have a pretty rigorous process involving our information services team, which involves medical librarians, as well as a diverse clinical working group that includes family physicians, nurse practitioners, caregivers, and representatives from the different stakeholder organizations within the topic. Academic detailers are also involved in both our tool development as well as our training. And for this topic, we also were really expanding into the area of electronic medical records, because falls is such a multidisciplinary, complex intervention that requires a lot of different facets. It's important for the whole office to be involved and for those records to be kept and communicated. So we also developed an electronic medical record tool together with a eHealth Center of Excellence. That tool kept track of the screening and identification of risk factors, as well as generated a patient action plan. So next slide. This was our fully virtual upskilling process. We upskilled during COVID. And so as a result, everything was virtual. We had 4 weekly webinars, a 2-day virtual upskilling workshop. And there we discussed our key messages and features, benefits, barriers, and enablers. We had a couple clinical meetings with those. with family physicians. And we also had a system of topic experts among the detailers, where for each of the falls risk factors, we would assign a detailer. So for example, medications would be one detailer, mobility devices would be another detailer, footwear would be another detailer. And so each detailer had a particular area of specialization that they could act as a resource during our training. And we also developed a question and answer document for the detailers for internal use, where when we went out to do our early visits, if there were questions that popped up that we hadn't covered in training, it was a way to aggregate that information so that detailers could save time on actually researching that. So you wouldn't have 3 or 4 detailers all researching and answering the same question. You could review that question and answer document before your visit and see what people had been asked about. And then we had the weekly check-ins as people were going along. This informed the development of 3 key messages: to screen everyone 65 plus at least annually, and then after a hospitalization or significant clinical change. Our second key message on the next slide is to conduct a comprehensive assessment to identify each patient's individual risk factors. What we found in the literature was that it was, rather than one particular risk factor seeming to make the difference, it was the understanding of the risk factors for that particular patient and developing a customized plan to address them. So on the next slide, you'll see our third key message, which was a tailored risk reduction strategy that was multifactorial for that individual. Next slide. We have our materials, which was our fall prevention and management tool. We also had an electronic medical record tool, as well as a checklist that could be completed by the patient within the office. And then we also had our internal question and answer document that was available to the detailers as they were training. Next slide. Thanks. We also had, and I just wanted to note, I've put a link to our chat in the chat to our Falls tool. We also looked at an environmental scan of local resources that would be useful for helping with the different risk factors, so we didn't reinvent those. We found handouts on exercise, home safety, postural hypotension, footwear, and also medication and tapering. And orienting clinicians to these resources was a huge win in terms of providing quick interventions that people could easily do with not a lot of time. Next slide. This is just a quick snapshot of our tool. We won't go into detail on it other than to demonstrate kind of the rough idea of the graphic design. Feel free to visit the URL so you can take a look at the tool in more detail. Next slide. This is a quick snapshot of our EMR tool. You can see that for each falls risk factor, there's a section where the clinician could suggest the appropriate interventions, and then using this, a personalized patient action plan could be generated. And that was a big time saver for clinicians as well. The checklist allowed the use of front office staff to help in completing the screening for individual falls risk factors, and they could complete this before a visit or while they were in the waiting room. Next slide. This is just some quick stats on our visits. We conducted 210 visits, primarily with family physicians. And next slide, you'll see average visit duration. They were pretty long at 34 minutes, and we had 11,000 downloads of our tool. Next slide. You can see that we spent approximately equal time on our key messages with a slight weighting towards the tailored interventions. And I've just received some updated satisfaction data that 100% of providers were satisfied with our service. 100% agreed that the detailer was credible. 99% agreed that the information was relevant to their practice. And 98% said that the visit improved their confidence to translate evidence into practice. So some pretty nice stats to see there. And some of the most common questions. I know we're getting near the end of our time, so I will pop through what people were asking. Number one thing was time. If you've only got a few minutes, what's the biggest bang for your buck? How do I help patients with the long wait times associated with the various social interventions? What can I do about frequent fallers? And how do I get my office staff involved? There was a service called Geri MedRisk, which was a free geriatric consult with a multidisciplinary team that could assist with complex elderly patients as well as deprescribing. And that was a very popular intervention as well. In terms of barriers to service time, as I mentioned before, the the can of worms idea that if you ask about falls, you're really opening yourself up to a lot of work, and the feeling of no matter how hard I try, these patients just keep falling. Next slide. So what we tried to do was to look for these easy wins, things like if you've got a complex patient, refer them to Jerry Medress for a consult. Refer to our home and community care service, which provides in-home nursing assessments and care and assistive devices. And to give people permission to ask the question, but not have to deal with everything all at once. So ask the question, get a list of the risk factors, but then take your time over a series of visits in working on those. If you have a ton of elderly patients, choose a high priority group to start with so it's less overwhelming. For example, everyone who comes back from hospital, everyone who comes back from a bone mineral density scan, and get your EMR involved, your electronic medical record, in searching for those high risk patients, getting families involved in discussion. So all things to make this process a little easier. Enablers for this, simple things like observing the patient's gait as they walk towards your exam room so it doesn't take any extra time. Asking simple screening questions like how often do you leave the house? This gets at social isolation plus how much physical activity they're getting and whether they need some social support, and what do you eat in a typical day? So rather than a detailed food diary, this gives a gestalt of, you know, are you eating tea and toast? Or do you have a good adequate food supply? Having a glass of water by the bedside was a popular tip for orthostatic hypotension. Nice, simple thing. A well-lit path from bedroom to bathroom, making sure that your shoes and your assistive devices are used indoors as well as outdoors, and having that fanny pack cell phone for being able to call in case you fall. Some folks also love the idea of using technology for patients who have access to that. Alexa, Google Home, you can say I've fallen and I need help. Very simple intervention there too. Next slide. So in terms of key learnings, the number one thing was time and complexity. And what worked for us was sort of the quick wins. Screen everybody 65 plus, refer everybody on 3 or more CNS medications to either a pharmacist or Jerry Medress for medication review, and provide some handouts, the ones we mentioned in the earlier slides. If you've got no time at all, just ask the question and give them some handouts to get started. From a detailer perspective, we found the topic experts in the Q&A document were really good time savers for us. And we use the time complexity barrier as a marketing technique in our email promotions to say, what are the 3 drugs you've got to watch for? What's the number one thing you can do to help? And so we try to sort of focus on saving time. Next slide. That is it for us. A few of the references that we use to inform our tool development, and I'd like to open it up for questions.
Thank you so much, Trish. And do not fear all, when these slides are made accessible in about a week or less, you will have access to all those great references that are in size 4 font. So Trish, wonderful. It's such a compelling topic. I know there will be questions from the audience. You know, I'm wondering, were rates of falls steadily increasing where this became the next topic that you needed to focus on at CEP?
So it was a huge practice gap that we did see. And what we found was that COVID was making this much worse. The reason is that people were becoming housebound at increasingly high rates. We noticed that during the COVID topic and the diabetes topic that we had before this one, that providers were reporting that their elderly patients in particular were not getting out of the house to come to their normal medical appointments. So this was a sort of a double-edged sword in that not only were they not being seen and not getting medical care, but they also were not being active. And there was nobody overlooking whether they were safe at home. So we did notice that as a pretty significant gap that increased during COVID for sure. A lot of fear and a lot of concern about leaving the house.
Absolutely, absolutely. And then I'm sure increased hospitalizations, and when there are falls, more likely, you know, the result being the more likely to have increased falls or continuous falls. Thank you for that. So important, and often, you know, the elderly population does get overlooked. So it's really lovely to know that you've been working on this. Mike, I know you have a question, and we'll have time for 1 or 2 more. So do pop those over into the chat. Mike, what do you got up your sleeve?
Yeah, I was getting, Trish, great presentation, really, and just remarkable, you know, feedback that you were getting from the clinicians detailing. I sort of wanted to back it up a little to the intro, because one of the, you know, there are a few topics like this, falls and a few others, especially in geriatrics, that are, really fundamental topics. But so many of the patients have complex, when I think about the patients with multimorbidity, they're the ones at the highest risk of fall, but they also have so many competing priorities in the course of a visit. And actually, in some ways, even with the COVID isolation, people were less active, but they also were behind on their screening and their everything else. And so I'm interested in what you found most successful for the sort of the sort of initial engagement part of the why is this the one I as a clinician I'm going to spend my time on versus catching up on their diabetes or their other screening and so on, because clearly once you got them engaged, their reviews were phenomenally positive, and people can learn from what you did and have a very compelling intervention. But it's the getting them engaged that I think can sometimes be a trick when there's so many competing priorities.
An excellent point, and definitely something we encountered. I think the biggest win for us there was the power of a story, where we would go with, as part of our needs assessment in the beginning of the visit, we would ask if they'd had a patient fall recently or anything particularly memorable in either their professional or personal experience with falls. And chances are, I encountered so many stories that way. Someone's own father had recently died from a fall. And if I hadn't asked that question, I wouldn't have been aware of that during the visit. The stories that we heard today, almost everyone had someone who had gone to ER recently or had a long wait at a walk-in clinic. And so we were able to engage with them by saying, tell us what you've been seeing with falls recently. And then we would couple that. Usually that would be coupled with a frustration around, it takes so much time to deal with this. How are we going to do it? And that's when we get into, well, you know what? All you have to do right now is just one thing. Just ask the question. And if you get an answer that's very complicated, that's fine. You've asked the question. You can deal with that over a series of visits. And so opportunistically, let's say they're in for a bone mineral density scan. Throw in a little bit about falls, give a couple handouts, get the family involved. If they're in for a question about their blood pressure, let's check the orthostatic blood pressure and maybe the footwear. And so you can kind of, while you're doing your exam, throw a couple things in. So you're dividing it up and you're tackling things in multiple visits rather than this terrifying 1 hour visit that the doctor probably imagines if they were to get through all the risk factors.
I love that. That's really helpful. And it brings up the quote we throw around here at NaRCAD so often: don't let the perfect be the enemy of the good. Any step, excuse me, any step you can make towards better is an improvement. So again, helping clinicians who are overwhelmed, don't have time, feel like if you can even take one step in this direction and reduce one person's, fall risk, you're improving something, which is not dissimilar to clinicians who feel overwhelmed by, say, the opioid crisis. I can't do anything. The quote that you had, Trish, that these folks are going to fall. There's nothing I can do. Inevitably, it will happen. The same thing around opioids. Folks are going to overdose. And if that's responded to with yes, and if you can help one person not do that, you're improving quality of care. This has been so refreshing, informative, and such a great way to prioritize folks who are often get missed out on, and especially now that folks are even more isolated. Thank you so much, Trish. And if there are any additional questions, please pop them into the chat and we will triage them over to Trish today. Thank you, Trish.
Thanks for the opportunity to present.
Thank you. And thanks for your whole crew at CEP with the shout outs and the team morale. We love it.
Yes, and we can't do all these fall visits without them.
It's true. It's true. All right, Anna, who's last for our yearbook presentation?
Yes, and thank you, Trish. We also have an interview with Trish from this past year on our website, so you can check that out as well. All right, our final presenter before we head into our final roundtable session is Megan Breckling. I am beyond excited for us to hop on the NaRCAD bus one last time and head to Arkansas. Megan is an academic detailer and an ambulatory pharmacist at the University of Arkansas for Medical Sciences and Arkansas Department of Health. She is part of a multidisciplinary team of detailers comprised of a pharmacist, physician, and a physical therapist that provide evidence-based solutions, tools, and support for chronic pain management to primary care providers across the state of Arkansas. It is my pleasure to welcome Megan. Hello, Megan.
And thank you for having me today. I'm really excited to talk about our program. And the name of the presentation, as Anna said, is Physical Therapy, Pharmacy, and Primary Care. And our program is a multidisciplinary approach to pain management. And the main thing that's kind of the main thing I want to get to today. So. All right, so I don't have any disclosures to disclose to you today, no financial or relationships to disclose. So some of the background on our program is Arkansas still remains the second highest opioid dispensing state with the rate that's nearly double the US average. So we still have a lot of work to do in Arkansas, and that is why our program was developed. And basically our goal is to increase primary care provider knowledge of alternative and multidisciplinary pain care and treatment while reducing opioid prescribing when possible. So you can kind of see these are the numbers that we've been looking at in Arkansas. We have gone down quite a bit. You know, in 2017, we were at 106 opioid prescribing rate per 100 people, and we have gone down to 75. So we are moving in the right direction, but just have some work to do still. Next slide. So this is the map that I get to look at quite often for our program. We get one of these every year that's kind of an update on how our program is doing and how the state is doing overall. So thanks to the Arkansas Department of Health, they're able to provide this to us. And it is from the PDMP that is here in Arkansas. And this is kind of what we use to target providers in Arkansas. So we look at it as a county-wide system. So we look for the counties that have the highest prescribing rates, and then we really try to target those counties and the providers that are within those counties. Not to say that we won't provide education to other providers in other counties, but we really try to reach those high-risk counties that are in the darker red of this heat map. Next slide. And our academic detailing program has grown a ton over the last several years, or 5 years. So it started in 2019, and it was a grant that was between the Arkansas Department of Health and the UAMS that started the program. At first, they only had one pharmacist that was providing all the academic detailing visits. So kudos to her for doing all these visits on her own. And they were all face-to-face in person at that point, and she was just focused on opioid prescribing. So she would just talk to them about ways that we could decrease that. Oh, sorry, if you could go back. And then our campaign kind of morphed into the second campaign is what we've been calling it, into a multidisciplinary team. The program thought that, you know, it was great having the single pharmacist, but we really wanted to get some perspectives from other disciplines into the program because pain management is such a multidisciplinary topic that we felt having academic detailers from these different disciplines would really make this program more effective. So now we have a multidisciplinary team of 3 academic detailers, a physical therapist, myself, who's a pharmacist, and then also a physician. And we expanded our topics. So we're not just doing opioid management, we're also doing benzodiazepine, some age-friendly healthcare, and we'll kind of get into the details of that in a second. And most of our visits have been virtual since COVID started, like most programs. And we're kind of learning about, you know, what that looks like for the future and whether we want to try to have more in-person visits as we go forward. Next slide. So here is our innovations for our program that I felt like I wanted to talk about today. So I've touched on the multidisciplinary approach, and we've also been able to get CE topic, continuing education topic for our 80 topics that we provide to providers. And the main motivator for that was we were having trouble, you know, recruiting providers and just having them see the benefit of meeting with us. So we thought, okay, well, let's give some continuing education, and then that will at least, you know, bring providers to us so we can build our network and provide them with something in return, and then also hopefully keep that relationship alive as we go forward with providing education to them. And then something that we're just starting to look into is assessing our program using some implementation science outcomes. So we have a great implementation science program here at UAMS, and I've been trying to connect with them and see kind of what we could do with our program to really produce some great manuscripts and papers that kind of look at our program better and how we have been able to implement all these evidence-based practices into different clinics and look at the outcomes of that. I'm
All
gonna turn
right,
it over
looks
to
like-
Devin.
Yeah, it looks like we have a slide here. All right, or excuse me, a poll. Which of the following would you be interested in incorporating into your AD program? So we've got A, multidisciplinary AD team members, B, CE credits or continuing education credits for AD topics, C, virtual AD visits, D, in-person visits, and E, assessment of implementation science outcomes. If you'd like more than one of these, pop on over to the chat box and show us every letter you want. All right, so it looks like we're leading with your approach, multidisciplinary AD team members, which is lovely. We have a couple folks who, look, nobody wants to do virtual AD right now. Oh, I take that back. Lucinda in the chat box is standing by as a virtual AD visit protector. But on the whole, we're far and above leading with the multidisciplinary team. All right, we'll hand it back to you, Megan. I can tell you're proud of that.
Yeah, that's really exciting to see. And that's one huge benefit I think our program has, is having this multidisciplinary approach. So I hope after this talk, maybe I'll be encouraging to you guys to look into that. So these are our different modules that we have for our current academic detailing project. So our first one is the one that started the program, the evidence-based pain management, opioid safety. And all of these key messages come from the CDC chronic pain guidelines. They will be updated here now that we've had new guidelines published. So I'm excited to dig into those and get our new materials out for that. Our second module is preventing opioid overdose with naloxone, and this really goes through the specifics of Arkansas state law and when naloxone needs to be prescribed for patients, talking about opioid safe language, and then just various forms of naloxone and how to use those, and then also a little bit about like billing and counseling with patients so that providers can be benefited for those services they're providing. Our third module is evidence-based benzodiazepine therapy. So benzodiazepines and opioids, as you guys know, they go very hand in hand. So we had to have a module that was specific to that we could also provide to providers. And a lot of this is similar to the opioid modules, you know, talking about, you know, other evidence-based non-benzodiazepine treatment modalities that are better for patients and safer, how to taper patients off benzos, when you can use benzos, when they're appropriate, and just looking at those risks and benefits. Those are kind of the key messages we look at for that. And then our final module is age-friendly healthcare, and this goes with the 4Ms framework from the Institute for Healthcare Improvement. So that stands for what matters most, you know, reducing high-risk medications, performing mobility screens, and then performing mind screens as well. So, and that was actually developed by our physical therapist who has been working on that with other grants as well. And all of these modules, providers get a half hour of CE for. So if they complete all 4 of them, they get 2 hours total. So that's kind of what we try to do, is we'll meet with them to give 1 or 2 topics and then line up another visit with them to maybe give the other 2 topics depending on what time they have. So these are some of the implementation science outcomes that our program has been looking into to use for future development of our program and looking at, you know, how well we're doing overall. So the kind of titles of those are dosage, quality, participant responsiveness, program reach, and adaptations. So these are just kind of themes that, you know, a lot of our programs are already looking at, but it's kind of putting them into the buckets of implementation science. So dosage, we're looking at the number, the types of providers, how many visits we give to each of them, the quality of these visits. So providing the evaluations, looking at the impact of their knowledge, competence, performance, patient outcomes, any changes to their behaviors, and then also barriers to these changes that they're trying to make, whether they're responsive to that. So that's been one that we've actually struggled with because of the limited data that we're allowed to have in Arkansas from the PDMP. So we've been exploring other ways to kind of link this, you know, besides just evaluations that we get from providers, to have some hard data that kind of shows our program is effective in helping with what we're teaching. Also looking at program reach. So are we delivering our education to people that we want to target? Are we reaching that population? And then adaptation. So we're always looking for ways to improve our program, ideas for future outreach. So we're always asking our providers, you know, what could we provide to you in the future that would be helpful for your practice? Okay, so let's look at some results from our program. So I said, you know, campaign 1, that was back in 2019 when we first started, and we just had the one pharmacist that was working for the program. She completed 103 provider education visits face-to-face, and this was in a very short time, so it was pretty awesome. However, one of the things that we found was the evaluations were a low rate of completion, so 30% response rate. So when they started the multidisciplinary team for campaign 2, that was one thing we really wanted to improve on. We needed more feedback from our providers on how to improve our program and what if it was helpful to them. So that's why we went into providing CE, and in order to get the CE, they had to fill out the evaluations. So that was a way to get our evaluations filled out more. And now we are looking at more of an 84% response rate, which is much better. However, our number of providers educated over the last year has been smaller than what it was previously. And some of the things I think that could have contributed to that is, you know, when you go face to face, it's very easy to just kind of pull all sorts of people into one room and provide a big visit. And some of the visits that this pharmacist did were kind of a lecture, more of a big group style education. Whereas now we are really trying to focus on getting those one-on-one typical AD visits with providers, and you know, your numbers are not going to be as large because you are trying to be more individual with that provider. So those are just some of the thoughts that I've had with that. And next slide. Okay, so looking at survey results, so this is from the first campaign. We had a 73% providers that said that their opioid prescribing changed in at least one area. And those areas are listed below there with the green line. So initiated taper schedules was 1, avoided concurrent opioid and benzodiazepine therapy. They were more likely to maximize non-opioid treatments. They prescribed fewer opioids. And then we did have 23% that said that they did not change practice. However, I feel like these results were pretty encouraging seeing that. And then on a Likert scale, there was, they said 8.4 out of 10 that the AD visits were useful. So pretty well, you know, we knew our program was helpful, but we just were struggling to get, you know, all the evaluations in, and also kind of where we should go with the program for the future. So looking at our new results, so this was just from this year. So we have had, you know, similar responses, except for more surveys completed. We've had 43% of providers say that they changed the management and or treatment of their patients. We had 10% say that they created or revised protocols, policies, and procedures. And we have about 47 that said it kind of validated their current practice, but they didn't make any changes. So I still feel like, you know, getting half the providers to really make some sort of change to their practice is pretty encouraging. And kind of looking at the other evaluations that the questions that we've had, you know, I think we need to dig a little bit deeper into, you know, why people are saying that it validated their current practice. You know, I think maybe that was just kind of something that people clicked and didn't really think about, if that makes sense. So kind of looking at the impact of AD visits, we had between 60 and 70% say that they had some sort of impact. So whether that improved patient outcomes, performance, competence, or knowledge, we hit one of those areas for providers. So we felt pretty good about seeing those results. So here are just some qualitative results, you know, that I have seen with our program as we have grown. I feel like in-person and virtual visits are both effective interventions to guide provider behavior. I was talking about yesterday kind of how I believe that maybe that initial visit should be in person because it does help build that relationship with the provider, and they're able to see what your program's really about and understand what you can offer them a little bit better than in the virtual environment. And then maybe moving to more virtual with like follow-ups to kind of help with the time and then the cost savings of travel and all that. So that's just one idea that I've kind of had. Increasing, so since we've had a multidisciplinary AD program, we've been able to increase those conversations with providers about, what is available in their community that is multidisciplinary for pain management. What can we offer as our program, maybe virtual options for patients to be able to do these different multidisciplinary treatments, or can we, partner with different people across the state? So this has kind of increased a lot of those conversations on what we could do to kind of help these very rural providers, since Arkansas is so rural with their counties. And then having that multidisciplinary team, I have seen our education materials just develop and grow and be better for providers. We kind of have different views of certain things, and we can kind of help with the development and making sure we're hitting the key points for things, and also kind of being the experts in certain areas so that when we have questions come up, we can really answer those questions effectively. And then we are working on, developing more topics for the providers that we're educating based on the feedback that we're getting. So we're very excited about that. Okay, so future plans, these are all very exciting. So we want to, expand our AD program to target community pharmacists. We feel like, with Arkansas being a very rural state, that community pharmacists play a huge role in the healthcare of patients. So we would like to kind of expand our AD program to provide them with education that they need for certain topics. And then also looking at the federally qualified healthcare centers of Arkansas. We began to partner with a larger organization in Arkansas to kind of help with that connection. So we're excited about that networking opportunity. Some of the new education topics that we are currently developing include mindfulness, stress reduction training, motivational interviewing and chronic pain management, opioid use disorder and treatment, and then also insomnia treatment. And we feel like all of these are different topics that providers have told us that would be beneficial for their patients. And then we hope to develop more manuscripts and papers that kind of look at our AD program and kind of that implementation science view, and hope to get those published in the future.
Wonderful. Thank you. And here's Megan's contact information, which we will also have available in our contact list at the end of the conference. And we'll make sure you get access to these references as well. We will have time for one question, which we have from Trish. And we also have a question from Cassidy Moab. I'm hoping as one of yet the many awesome partners in crime of our presenters, that you'll be able to answer that in the chat. I'm going to turn it over to Trish. How do you measure whether you are reaching the providers you wanted to reach? Is there a master list that you follow up with?
Yeah, so I think we would kind of reference that county map that we get from the Arkansas Department of Health and look at where these different providers that we're reaching, which counties they are in, and then kind of link that to, we're trying to reach those high counties, the real red counties in that map. How many providers did we reach in that specific county? That would be one way that we could do that.
Excellent. And Moab, if you have a second to answer this other question, or maybe Megan, you can answer it real quickly. It looks like the evaluations were driven by continuing education, and it sounds like the feedback from evals reflect more on the effectiveness of the group only, not the one-to-one, or is the CE available for one-to-one as well? If you can quickly speak to that.
Yes, so our CE is available for one-on-one or small group sessions. So we provide that to anyone that meets with us for an AD visit. And that was actually something that we had to specifically request from our CE office because they are not as familiar with, kind of this one-on-one situation instead of a large lecture. So we had to meet with them and discuss with them about what our goals were and why we wanted to provide the CE. And then that's when they were able to approve us to give that CE on a one-on-one basis instead of such a large group as it normally would be.
Okay. Thanks for answering, guys. We are about to go into a break. I know we have stolen some of your break in the past. We're going to give you more time this time. Please head on back at 2:50 instead of 2:45. I want to make sure you have plenty of time to stretch and breathe. Then we'll come back into our final session for the day. It's interactive. It's for you to inform 2023. Thank you to our three presenters, Trish, Megan, and Connie. And we will see you all at 2:50 EST. Thanks very much. We are welcoming folks back after a full and fabulous day for the final session. We're going to go out with a bang. For those of you who are too tired for that, take a little bit of a longer break and get a little more caffeine, or just maybe shut your camera off and just give yourself a hug. All right, Anna, we ready to rock and roll? Anshul, you want to record?
Recording's on.
Oh, sorry. Those of you watching the recording, I apologize. All right, here we go. Anna, what is happening now?
Yes, so it is time to network with your peers and continue to build on the relationships that you've all built with one another over the past 3 days. And we want to get you excited and ready for 2023 and make sure you have the support you need from us at NaRCAD as well as from the entire AD community.
Yep, what she said, absolutely. We're talking about not just networking with each other though, looking to us to ask us to create that space continuously. So let's talk about what this looks like. We're tying in our 10th conference theme of celebrating community engagement with the space you've brought us to in the past 10 plus years of being NaRCADians. So let's talk about what that looks like. Anna, take it away.
Yes, so let's talk about some of your strengths. And your strengths as a community are you're there to mentor and support each other, share critical tools, resources, and links, strengthen your communication skills, join interactive small and large group discussions, share best practices, develop problem-solving skills, and enjoy the work that you're doing and have fun while doing it. We have seen every single one of these strengths over the past 3 days, and that is truly something to be proud of.
Absolutely, and we've noticed that the silliness factor has been increasing over the past decade, which is something that we actually all really, really need. We need to be able to laugh more, and we also need to feel that what we're doing is enough. So again, we encourage you to go into this final session finding that sweet spot between, hey, how can I improve? How can we feel good going into 2023? While also saying everything I've done up until this point is enough for now. So we encourage you to kind of lean on your successes. And of course, now, I guess since we've hit Halloween, I think it's allowed to say, we'll talk about that in the new year. So rest on that if you would like to. I don't think much to say here, Anna. What do you think?
Yeah, I was going to talk a little bit about your welcome letter and bring it back to what the wonderful things you said in there. So
okay, the bat signal. Yes, let's talk about that.
So we know that our community is incredibly supportive and innovative, and Bevan shared in her welcome letter the importance of supporting one another and boosting morale, and how well you've all done at that. And the last 3 days have really taught us that we are each other's cheerleaders. We're asking each other's questions, we're sharing best practices, and we're connecting with one another on a human level so that we can share the best evidence with the clinicians that we're working with. So Bevan, I will turn it to you to open our roundtable session.
Absolutely. And we would ask just this one last time. I know you're hanging on. I just paused my camera to just take a sip of tea and eat a bite of a sandwich, so I'm with you. But if you can throw your cameras on this one last time, if possible, we would love to wrap up with a bang here. So what we want to talk about is what is on your mind, for the year to come, where you are now, where you want to go. And here's some things you can think about if you don't even know what's on your mind, if it's a blur, if you're not sure where to start. Some things you can think about if you're learning where to start is what's the clinical focus? And if you're not sure of that yet, starting to think, what does your community need? What are folks saying? What are trends? Look at data. Are you starting to think about program development? If so, you can pick the brains of so many folks who have been here for the past 3 days and beyond. Anshul has popped the conference hub info into the chat box early each day. We will make sure you receive it, but it has video and content from the past 10 years. I know that sounds overwhelming. You don't need to read 10 years worth of content all in one sitting or at all, but it's there for you. Recruiting and training. This is where we come in as the experts. You all are the experts on the ground, but at NaRCAD, we are the ones who want to get you ready for showtime. So we can help you with staffing, hiring, getting ready to do these visits. And of course, integrating into the detailing community, not only by talking with clinicians, but talking to each other, making sure you feel connected, minimizing isolation, feeling like it's normal to have just not a great visit. We're going to talk to you over the years to come, but particularly going into 2023, about finding ways to build capacity, especially for those of us who feel like just maintaining our current level of capacity would be fantastic. We want to help you get a few steps ahead. How can you be sustainable? How can you connect with public health and leadership and community stakeholders and health systems in ways that aren't just temporary, aren't for one pilot program, but are long-standing relationships that you can continue to build? And this is where some folks really need extra help, and where we have been growing over the past few years in particular, is trying to help you track your progress and prove to stakeholders and funders that your work is critical and deserves to continue. So we can talk to you about that as well. But of course, we've got a poll. Anna, last time to get folks back on the wagon for the poll.
Yes. All right. Take out your phones. Probably for one of the last times. We have a few more polls. Text the number 37607, and you can text the word NaRCAD 1108 to join the room.
If you're still having a hard time with that, the chat box is your trusty, lesser technologically savvy friend. So do not fear, do not have shame. Use a chat box. All right, here's a question, Anna. This is a question that's very Annalicious. It's very positive.
What is a strength of your program or your organization?
Pop it on in and don't be shy.
Oh, I love this one as the first one. The people.
Ooh, collaborative approaches. Love that.
Team dynamics.
Mm-hmm. The team itself, of course. These are great things to be able to say. For those of you who are sitting there shedding one solitary cold tear because you are the team, let us be your team. Anna, what else are we seeing?
Collaboration, another one for the people. Employee dedication. Great people.
Yeah, great people. Me. That was wonderful. That reminds me of when Snoop Dogg got a Grammy. He said, I would like to thank me for working so hard. Hashtag Snoop Dogg. Partnership, evidence, consistent funding, support from management. Yes, and for those of you who are like, God, I would love these things, we will help you get there. A few more, Anna, what are we seeing?
Years of experience, support, long-standing relationships.
Mm-hmm.
Another one
for
for the
team. Big thread there with the team. And one thing I want to say to those of you who would love to have long-standing relationships, those relationships were once first-time relationships. So again, you will get there. All right. Now I want to know, what do you need the most support with? And I don't want this to be framed as, where are you weakest, but where do you want to grow most? Or where is there a blank space you want to fill in? And I love this tie over from the last question. We all bring something different to the table. All right, so Anna, I'm seeing help with evaluation. That is not a surprise. Spreading an evidence base, engaging and getting one-to-one customers. I love that. Let's start calling clinicians customers. What else, Anna? What are the next three that we say?
expanding topics, my versatility as a detailer, materials development. I'm going to do
detailer recruitment. Yes, we want to help you bring people into the cult of detailing. We want help. You want help being more engaging, more confident, Again, with recruiting new personnel, we can help you with that, seeing a lot of that. Not surprised. Anna, what about this juicy one?
Partnering with other detailing programs and knowing what they're working on. Yes, and we at NaRCAD can help you with those peer connections, and we can make those connections for you. So reach out to us if you want to connect with this team.
Continued buy-in, nothing. I'm not yet trained. Let us help you with that. Come to hang out with us in January. Long-term commitments from funders, provider feedback, making a butter chicken that is restaurant quality. Yeah, we're going to tee that over to Canada. Outcomes, need to feel refreshed. Yes. Provider recruitment, getting the in, clinical materials development, etc. Just so many things here. And again, this is our wheelhouse. And if it's not, we will take the expertise of our colleagues from across the globe. And continued support working from home. Yes. You can talk to me one-to-one. I will support you. Love working from home. Some people, that's just painful. If you need support, feeling good about working from home, I have tips and tricks. I am wearing skull and crossbone pajama pants right now. I'm not going to lie. So we can talk about that. And again, it just seems like folks need support with the things that, of course, you would need support with building a program. All right, Anna, so take us away into what the next little bit will be about.
Yes, so we are going to spend the next 15 minutes in breakout groups, and we want you to have a space to share with your peers. So please encourage each other to chat and open up in these discussions. And if you're having trouble starting the conversation, a tip that we have heard from one of our colleagues is to have everyone speak in alphabetical order. So if I was in the room and Bevan was in the room, Anna would go first and then Bevan.
Figures. Just kidding. All right. And again, please don't be shy. We've had comments on evals that we just sat there. We didn't know how to start. Please start. If you're going to be a great detailer, you got to not be shy. So please start. If it's hard, you can move through that awkwardness together. And let's talk about the prompts. Okay, so this is going to be a juicy one. You got 60 seconds to each introduce yourselves, and each of you should talk about one strength and one area where you need support with academic detailing. Don't say, I haven't even been trained, I don't have a strength. Talk about what strength you have as a communicator, anything in that realm. Do not be shy. How many times do we get a chance to sort of toot our own horns? And if you have more time, talk about solutions for areas where your colleagues have asked for support. As you'll see, Anshul popped these into the chat box, so you will not lose the prompts. Try to enjoy yourself, and we'll see you in 15 minutes. Anna, last kind of housekeeping slide before we let folks go.
Yeah, if you please turn on your video and for at least these 15 minutes and really engage with the peers in your group. And if you need help during the session, you can request help from the host on the toolbar, and we will send you a reminder when there's 5 minutes left before we're going to bring you back into the main room for a large group discussion and our wrap up. So enjoy.